All right, class. So welcome back. So here we are, Monday. I just wanted to talk us through kind of our schedule for this week. We have some things coming up. Um, Let me know if my internet or my connection, if I sound okay, as well as we're going through this. But this week in class, so today we're just going to finish the chapter 6 on the skeletal system. And then in lab this week, you guys have your first lab exam. And how I'm going to do it, if you guys have me for lab on Monday, we're going to go over the exercise first, exercise 7. So I'll lecture on exercise 7. I'll give you the Google lab activity link, and then I'll give you the lab practical link, just so that when you're done with the lab exam today, you're free to go. So that's kind of what we'll be doing in lab. And then lecture, you guys have another lecture exam on Wednesday, but it's just on chapters 5 and 6. So remember, chapter 5 was the integumentary system. And then chapter 6 is what we're finishing today on the skeletal system. And then let me take you, I just posted one more announcement this morning. This doesn't really apply to you yet. So how we do a couple take-home lab kits, and you guys will have to pick up these lab kits. You won't be picking them up until the weeks of October 11th and November 29th, but we do have a lab tech who can mail your kit out to you if you have an extenuating circumstance or if you live more than 3 hours away. So send me an email or a message with your physical mailing address if you apply for one of these extenuating circumstances. If you can't pick up the lab kit on these days, so again, just take a look at these days and times. If you can't pick it up during these days or times, let me know. You could send someone to pick it up for you. So I just wanted to throw that on your radar that eventually you'll have to pick up 2 lab kits. You have to pick them up on 2 different days because the urinalysis kit cannot be it can't sit out at all. So that's why there's 2 separate days to pick up these lab kits. So I just wanted to throw that on your radar. So keep that in mind. Any questions on any of that before we get started? Okay. And I'm still sounding okay? The connection, just let me know. All right, thanks guys. Okay, so here we are. We're just going to finish up the skeletal system. We talked a little bit how bones are formed, and we got through some of the bones and features in the skull, which you guys will review when we eventually get to the skeletal system in lab, which I believe will be next week. So we'll kind of continue our talk on the skeletal system, and we'll move on to paranasal sinuses. And sinuses are spaces or cavities within your skull bones, and several of the bones associated specifically with your nasal cavity are called the paranasal sinuses, which open into your nasal cavity. And they're named for what bone they lie in. So you have a frontal, an ethmoid, a sphenoid, and a maxillary sinus. So these are kind of just spaces or cavities within different skull bones that allow the skull to appear lighter. They also help with sound resonation. If you have a sinus infection, it'll usually be an infection in one of these sinuses. And if you are sick, these sinuses can fill with mucus. So that's why when you're sick, that idea, you kind of sound funny. It's because these paranasal sinuses are usually filled with some sort of junk or bacteria. So these are paranasal sinuses. And again, they're named for what bone they are within, and they are just cavities or spaces within the bone. So the frontal sinus is right at the front. There's a space. The ethmoid sinus is in the ethmoid bone, or with their little tiny spaces. Remember, the ethmoid bone is the bone that sits behind your nose. Sphenoidal sinus also kind of sits behind your nose. And then the maxillary sinus is the bone that makes up the top part of your jawbone. And again, all these sinuses are associated with the nasal cavity or with the nose. So those are paranasal sinuses. Then we'll go on to the hyoid bone. So we got through the skull, we'll get through all the axial skeleton, and then we'll go to the bones of the appendicular skeleton. The hyoid bone is a little U-shaped bone. It's not a part of the skull, and it has no direct attachment to the skull or any other bones. It's very unique as being the only bone in the body that does not articulate with any other bones. So your hyoid bone just kind of sits right below your skull, kind of around your larynx, and it's held in place by different ligaments and muscles. It's important as providing an attachment for some of your tongue muscles, as well as an attachment point for other important neck muscles that will elevate the larynx to help you swallow. So here's a look at your hyoid bone. It sits kind of right underneath the jawbone, but you can't really reach it or you can't really touch it. A little CSI kind of fact for you that if the hyoid bone is ever broken, so let's say you come across a dead body in the woods, and I use that often, you come across this skeleton in the woods and their hyoid bone is broken. What did that person die from? What do you guys think? Okay, Matt is actually doing the action in the camera, so thank you. So yeah, not to get super gruesome, but if the only way the hyoid bone can break is if someone is strangled, either by a hanging or physical strangulation. And it's why that's bad is the hyoid bone directly kind of circles or go around your larynx or the top of your voice box. For someone to be strangled, their hyoid bone would usually crack. So that's an easy way to see if someone's been strangled. All right, moving on from that, we'll get to the vertebral column, which is just another word from your spine. It's the central axis of the skeleton. It extends all the way from the base of your skull to just slightly past your pelvis. And in adults, it consists of 26 individual bones, and they're grouped into 5 different regions, which we'll go over. The vertebral column or the spine also has 4 major curvatures, and I'll show you a picture of this. So the spine that helps you sit up straight is not completely straight. It is if you're looking at it, down the midline, it should be straight so you don't have scoliosis. But in terms of how it holds up your body weight, your spine has these curvatures, and we'll talk about that. And they're named for the regions. The cervical region curves more anteriorly. The thoracic region curves posteriorly, the lumbar region curves anteriorly, and then the sacral and coccygeal regions curve together posteriorly. And this kind of curvature, which I'll show you a picture of, is very important for helping your body kind of sit up straight and hold all your body weight. So here are the number of vertebrae, or the little bones that make up each region in the vertebral column. You have 7 cervical vertebrae, 12 thoracic vertebra, and 5 lumbar vertebra. And when I was studying this, my professor kind of gave me a little hint. You eat breakfast at 7, lunch at 12, and then supper or dinner, whatever you want to call it, at 5. So if that helps you remember the number of vertebra in each region. And then the sacrum and the coccyx, we just say you have 1 sacrum and 1 coccyx, because these vertebrae that make up those regions ultimately have been fused together. And the coccyx is just another word for your tailbone. In the cervical vertebra, the first 2 cervical vertebrae that are right underneath the skull are a little bit special. So the first cervical vertebra, often called C1, that is also called the atlas, and that holds up the skull or the head. And then the C2, the second vertebra, is called the axis, and that will rotate the head. And I'll show you pictures of these in a little bit. The functions of your vertebral column: it supports all of your body weight. It also protects the spinal cord. So the spinal cord is the nervous system continuation from your brain that travels down, and it travels through the vertebrae in little holes that each vertebra make. And your spinal cord traveling through the vertebrae will have different spinal nerves that exit out of it. Your vertebral column also provides a site for muscle attachment, as well as providing movement of your head and trunk. So here's a good look at your vertebral column. You can see here the curvatures that I was talking about. So here's the cervical region. And again, you have 7 cervical vertebrae, and you can see how it kind of curves anteriorly. And then the thoracic region kind of curves posteriorly. And then the lumbar region curves more anteriorly. So in terms of 4-legged animals, or animals that walk on their hands and feet like a cow or a dog, they don't have these nice curvatures as much because they don't have to support their body weight. Us as humans, we do have to support our body weight, and we walk on 2 legs. So that's why we have these curvatures in our vertebral column. And babies or infants, these curvatures won't be very pronounced or visible really until they start walking. So, we think about why babies can't walk sooner. Well, their vertebral column hasn't kind of made these curvatures yet to hold up their body weight. So that's why you don't really want your baby walking before 11, 12 months. You want them to learn how to crawl first, but also just so that their vertebral column can completely form these curvatures of the back so that when the baby is ready to walk, it can hold up their body weight. So here's kind of the anatomy of a typical vertebra. Then one thing you'll notice through all vertebrae is they have this hole called a vertebral foramen. Remember, the word foramen means hole. So this is what the spinal cord will travel down. And then you have kind of the other very couple typical parts is the spinous process. And this is the part that sticks out that you guys can feel. So if you run your finger along your spine, you're touching all of the spinous processes of each individual vertebrae. The body of the vertebra is where the intervertebral discs will sit on. And then the transverse processes, if your spinous process comes straight out, your transverse processes come out perpendicular to that. And if you dig deep, you can actually feel the transverse processes on the lateral side of each spinous process. And these transverse processes are what a lot of chiropractors will use to kind of adjust your spine so they can push to either on the right or left transverse process to kind of get your spine aligned. Articular facets, that whenever you see the word facet, it usually means it's a connection point between another bone. So this is where the vertebra above will kind of touch the vertebra below. The superior articulating process is just a kind of a process that reaches up to the top with that facet. The lamina of the vertebra are kind of the curved walls, I guess you could say, that will reach to a point. So you'll see a lamina and a lamina kind of coming together to form the spinous process. And then the pedicle is just kind of the connection piece between the posterior part of the vertebra with the body. So that's the anatomy of a typical vertebra. And then there are differences between vertebra in the body. So your atlas, which is again the first cervical vertebra, it has a hole in it for the spinal cord to come down, but it doesn't have a spinous process. And it has these facets for not only the dens to sit in, which is your C2 atlas, but also it has these superior articulating facets where the occipital condyle, which is the base of your skull, to kind of sit. So you have your skull kind of connecting real nicely with the C1, the atlas, and the skull sitting on top of your atlas. If I had a skull here, I would show you that's what allows you to nod your head yes. So that kind of gives your skull the ability to nod. And then C2 is the atlas. It has, I call it the thumbs up feature. So if you're looking at where the dens is, this is also called the odontoid process. I call it the thumbs up of the atlas. What we have here is we have the atlas kind of sitting within this axis region of the dens. And you have different ligaments that connect your C1 to your C2. And when they connect the atlas, because it has this dens sticking up, it allows your head or your skull to shake your head no. So that when you do the no shaking of your head, your atlas and your axis are kind of just crisscrossing each other or rotating around each other. So that's the typical C1 and C2 are very unique. The other 5 cervical vertebrae have spinous process that's bifid, or it splits into 2, and you can see that there. It has a smaller body because it's only supporting the weight of the head at this point, and the vertebral discs will fit on that body. The other really unique part about a cervical vertebra is that cervical vertebra have these transverse foramen, which are foramen or holes within the transverse processes. Thoracic vertebra, again, these are all superior views. They have a kind of a little bit larger body because they're starting to withhold more of the body's weight. You can see the spinous process with the lamina, the facets for the rib attachment. So I remember you eat lunch at 12. So you have 12 thoracic vertebra, and you have 12 pairs of ribs that will connect to these vertebrae. So your ribs that make up your rib cage connect to the breastbone or the sternum in the front, and then they connect posteriorly to your thoracic vertebra. So you'll see facets or attachments where those ribs will attach. And then the lumbar vertebra, these are the lower 5 vertebra that make up the lumbar region. They will have the largest bodies, and that body again will be very thick to support all the body weight. Because if you think about your lumbar vertebra, it's in the lower back region. These vertebrae are really supporting the majority of all of the upper body weight. So the body, the anatomical piece of each lumbar vertebra, will be very thick and very wide. So again, this is showing you have one sacrum and one coccyx, but you'll see what we call the median sacral crest with kind of individual spinous processes that fuse together during embryological development. So at one point, the sacrum during embryological development in the womb did have separate vertebrae, but they all fused together to form one sacrum. And then the coccyx is just another word for your tailbone. If you've ever bruised your tailbone or thought it was funny to pull a chair out from somebody and they land on their tailbone, it can be extremely painful. And I once heard a story, this was back in grad school, of a little girl who was 4. She broke her tailbone, her coccyx, so that it kind of curved up into her pelvic region. When she's 4 or 5, it didn't really matter, but she got to be 25. She was about to give birth to a baby, and the baby didn't have enough space to come out. So they had to re-break her coccyx to kind of allow for space. That's my one coccyx tailbone story. All right, you also see holes. Whenever you see these holes, that's usually where spinal nerves will come out of, or different blood vessels. And the sacral promontory is kind of like a lip or a jutting out of the sacrum, where the L5, the 5th lumbar vertebra, will sit on top of. Okay. So then the last part of the axial skeleton, so remember we're all in axial skeleton here, is the thoracic cage. And your thoracic cage is also known as your rib cage. It's really important because it protects a lot of your vital organs, your heart, your lungs. There's 12 pairs of ribs. There's the sternum, which is also known as the breastbone. Your true ribs, so you have about 7 true ribs that will attach directly to the sternum by cartilage. You have a couple false ribs, which attach indirectly to the sternum, and I'll show you a picture of what this looks like. And then you have a couple floating ribs that they do not attach to the sternum at all. So, if you think of your ribs, they all attach to the spinous process on your spine, and they come around and attach to the sternum. You have a couple ribs that are just floating kind of in the back. And you can see these floating ribs here where they don't have any attachment to the sternum. They're ribs 11 and 12. You can see the sternum here. The different parts of the sternum is the manubrium, the body, the xiphoid process. And then you see 1 to 7 are considered true ribs, because you'll notice they have a direct attachment to the sternum. The false ribs, 8, 9, 10, 11, and 12, well, 8 to 10 are indirect because they attach to the sternum, but kind of by using another indirect piece of cartilage. And then 11 and 12 are also false ribs. They are your floating ribs. So that's your thoracic cage. And then we get into the bones of the pectoral girdle, and we get to the appendicular skeleton now. The xiphoid process of the sternum is usually the region that you want to locate for your 30 chest compressions. And I just have to put in a plug for The Office, the CPR episode. And usually when I was in person, I'd show that episode, if you know what I'm talking about. It's like the funniest thing you'll ever see on TV, but you watch it after class, CPR office episode. Okay, so now we'll get into the appendicular skeleton. We start by talking about girdles. And there's 2 girdles in the body. And when we're talking about a girdle is a part of the skeleton that attaches the axial to the appendicular. So the first girdle is the pectoral girdle. And this will be kind of the bones that will attach your arms to your axial skeleton. And what makes up the pectoral girdle is your scapula and clavicle. So they are no longer known as a shoulder blade and collarbone. You'll want to refer to them as your scapula and clavicle. And here are the pectoral girdle. The clavicle will attach to the sternum, and you can feel your clavicle or your collarbone and where it attaches to your sternum. And if you kind of follow your clavicle out, you get to a kind of a bony, bumpy part on your shoulder. And that bony, bumpy part is where your clavicle is attaching to your scapula. And then the humerus, which is your upper arm bone, kind of has a head that will make a ball and socket joint with your scapula. And then the radius and ulna are the two bones in your forearm. Then you have carpal bones are the bones in your wrist. Metacarpal bones are the bones in the palm of your hand. And then your phalanges are the bones in your digits, which you guys can freely move. You cannot really freely move your metacarpals because they're in the palm of your hand, but you can freely move the phalanges. So here's the scapula and clavicle. Again, in anatomy, we're not just going to learn the scapula, clavicle, humerus. We're also going to learn the different bony projections and bony landmarks on these bones. And again, we might go over this kind of quickly now, but you'll be spending at least 2 full days in lab just learning about the axial and appendicular skeleton and kind of the different bony projections that are on each. So here's the front or anterior side of the scapula. You can see the coracoid process, acromion process. That's the bumpy part you feel on top of your shoulders. And then we name the borders of the scapula for which side of the body they're on. So the medial border will be closer to the midline. The lateral border will be further away from the midline, and your lateral border will be connected to the glenoid cavity, which is where the ball or the head of your humerus will sit. On the posterior view of the scapula, which is shown on the right, you can see the spine of the scapula, and you can feel the spine of your scapula in the back and how it kind of angles down towards the midline. And then here's your clavicle, the distal end, the proximal end. So in terms of proximal and distal with your clavicle, the proximal end would be the part that attaches to your sternum, and the distal end will be the part that attaches to the scapula. And this is just looking at a superior view. So if you're looking from the top down at the top of your shoulder, you can see here how the clavicle attaches to the acromion process of your scapula. Then here are the upper limb bones, your humerus, the ulna, the radius, the carpals, and the metacarpals. And you can see them all labeled here. We're going to go over through each one individually. But again, spend some time just learning the basic bones of the body in the order that they go in. Here's the humerus. You can see the head of the humerus. This is what will fit into the ball and socket joint or the glenoid cavity of the scapula. And then we have what we call tubercles. And if you remember from Wednesday, a tubercle is any bony prominence on a bone. So the greater tubercle is a bump on the lateral side of the humerus. And the lesser tubercle is a bony little bump or prominence on the anterior side of the humerus. So those are greater and lesser tubercles. The lesser is a little bit smaller. We describe the necks of the humerus. The anatomical neck goes around the head, and the surgical neck kind of goes more around the body or the shaft. The deltoid tuberosity is a little raised bump on the humerus, and it's really hard to see in real life or on a model, but the deltoid tuberosity is where your deltoid muscle attaches. And if you kind of lift your arm up, if you abduct your arm and you can kind of feel your shoulder muscle, that's your deltoid, and you can kind of feel where the deltoid ends, that's where the deltoid tuberosity would be on the humerus. The distal end of the humerus has a lot going on because it has different kind of articulations where the elbow or the olecranon of the ulna bone will attach. And we have different condyles or smooth round processes that are covered with articular cartilage to make a nice kind of connection with the ulna or your olecranon, the elbow. The capitulum looks kind of like a small marble shape, and then the trochlea is a little indented. It kind of has an hourglass shape to it that's on its side. So those are kind of some unique structures about the humerus, looking at it from the anterior view. The posterior view of the humerus has a big fossa or depression called the olecranon fossa. And this is where the olecranon of the ulna will kind of fit into the humerus. So if this is your kind of the distal end of your humerus, the olecranon kind of curves up around it, so it can kind of do this movement of your elbow, of flexing and extending your elbow. So here are the forearm bones. So you have two bones in the forearm, the radius and ulna. The radius and ulna are very unique. So in anatomical position, you can kind of see the skeleton there. In anatomical position, remember the palms face forward. And in anatomical position, the radius always lines up with the thumb. So if you can kind of remember that, the radius always will line up with the thumb. And then when you do this kind of pronation and supination of moving your forearms up and down, your radius and ulna kind of are parallel, and then they crisscross each other as you move your forearm up and down. Because your radius and ulna are parallel, and then they'll crisscross each other when you kind of do this action with your forearm. This is often a common site of breakage with really anybody, but kids, when they break their arms, if they're quickly trying to put their hands down like this, or if they just fall on their arm, because these two bones are not very stable, or they can, they're crisscrossed, you'll often see little hairline fractures or complete breaks in the radius and ulna. You can see here different parts. The olecranon process is what reaches up and touches the humerus. The head of the radius looks like kind of a golf tee, if any of you play golf. And then you have styloid processes at the bottom. The head of the ulna is at the bottom. And you can see here from a superior view how they kind of connect together. My daughter broke her radius and ulna back in May. And I think I told you this on Wednesday, and she's getting the second pin out tomorrow. So if you were looking at the radius and ulna, she had one pin put in her radius to kind of help the bones to go together. And she had another pin that was put in the length of her ulna because she broke a wrist bone. So that her pin had to stabilize one of the bones in the wrist that she broke. So she has to go under anesthesia tomorrow to take it out, which I'm not super excited about, but it makes sense because they don't want the kids to move. So I'll let you know how that goes. I'm sure she'll come through fine. Here are the bones of the wrist and hand then. So you can see here how the radius and ulna kind of connect to your carpal bones, which are the wrist bones. Again, your radius is always the forearm bone that's connected with your thumb. So just to keep those straight. These are the carpal bones in order from kind of a proximal row and distal row. I have a clean and dirty version of how to remember the names of this, but I'm only going to show you the clean one. But so here we have scaphoid, which starts on the radius. So scaphoid, lunate, triquetrum, pisiform. So those are kind of the first row, the first four row of carpal bones. And then the distal row, we have, I'm going to start on the thumb side, trapezium, trapezoid, capitate, and hamate. So those are the kind of the rows in order of carpal bones. In terms of how much of this you need to know, you might have to identify a carpal bone on a lab exam, for example. So, for lab, you should probably study a little bit more. But if you remember this, Sally left the party to take Kathy home. And I'll write that in the chat quick just for you. It might help you remember the order of them. Again, the order of this goes from proximal row to distal row and always starting on the thumb side. So Sally left the party and then to take Kathy home. This is just a mnemonic device to help you remember the names of those carpal bones. And then, like I said before, the metacarpal bones are in the palm of your hand. They're numbered 1 through 5, always starting number 1 with the thumb. And then the digits are made up of your phalange bones. And the phalanges we name for being proximal phalanges. So the phalanges that are closest to the metacarpal bones. And then your 4 kind of these fingers have middle phalanges. And then they all have a distal phalange. And that's because your thumb just has a proximal and a distal phalange because your thumb can only bend in 2 spots. So that's why your thumb just has a proximal and distal phalange, whereas your fingers can bend in 3 spots. So your fingers have proximal, middle, and distal phalanges. All right, so moving on to the lower limb. How are you guys doing so far? Good, okay. So we have another girdle. So there's just 2 girdles in the body. The pectoral girdle is where, which makes sense because think of your pectoral or your pec muscles. That's where your axial skeleton connects to the upper limb. The pelvic girdle is where your lower limbs attach to the body. And what makes up the pelvic girdle are 3 bones that are kind of fused into one. The pelvis, which includes the pelvic girdle and the coccyx, the ischium, and the ilium. And then the acetabulum is the hip socket or joint. All right, so here is just a look at the pelvis. And I kind of misspoke there. I'm going to talk about the three bones that make up the pelvis in a little bit. So here is the pelvis, and you can see here how the pelvis will connect with the sacrum in the back. So we call where the sacrum connects to your pelvis the sacroiliac joint on both sides. You can also see here kind of some highlights of the pelvis. You have an iliac crest, an anterior superior iliac spine. We'll go over some of this in a little more detail. Your pelvis has holes in it called obturator foramens. The angle of the pelvis, so you have kind of two pelvic bones called coxal bones. They come together and they form an angle called the subpubic angle. And the pubic symphysis is the little piece of fibrocartilage that connects the two pelvis bones together in the front. The pubic symphysis will actually soften and to allow the pelvic bones to separate during labor and delivery. So females their pelvics will actually completely separate, come back together, more or less. And then the subpubic angle. This is the angle that the two pelvic bones make together. In females, the subpubic angle is much wider, and I'll show you examples of that. And in males, it's much more narrow. So this is the pelvis, and these are the hip bones. You have two of these hip bones that come together in the back at the sacrum and in the front at the pubic symphysis. And shaded in different colors are describing the three different bones that make up these hip bones. So your hip bones are made up of three different bones. The ilium is in dark green. That makes up kind of the top half. And then the bottom half is divided with the backbone called the ischium. And then the front blue is called the pubis. So these three bones come together and kind of fuse together at an area called the acetabulum. And the acetabulum is where the head of your femur will sit to make the ball and socket joint of your hip bone. The ischial tuberosity is a big bump at the base of the ischium. The ischial tuberosity is what you're all sitting on right now, kind of the butt bone. The greater sciatic notch, you can kind of see this notch structure here, will end in an ischial spine. The iliac fossa is an indentation on the anterior side of the ilium. So you see, again, a lot of different structures of this. No problem, Lorraine. I just got your message. That's okay. So here we have the hip bone. These three bones will come together and fuse during embryological development. And because they're three bones that have come together and fuse, many times in the elderly, this will be where osteoporosis sets in, where the bones will become a little bit more fragile. So if grandma or grandpa break their hip, it's also often in this acetabulum area because these are three bones that have, come together and fused during embryological development, but they can sometimes be the place where osteoporosis can sit in. So here's a male and female pelvis comparison. Again, if you come across a skeleton in the woods, you can take a look at dental. You can take a look at a lot to determine male versus female, but another place to look at is the pelvis. So the male subpubic angle is much more narrow. The female subpubic angle is much more wider or obtuse. And again, that's just to help with childbearing. You'll also know the female pelvis, the ilium bones, which are these bones where my cursor is, they kind of are a little more fanned out. So you notice in general, females have wider hips, and that's just because, due to childbearing, their hips are just a little wider. They also have different sizes of their pelvic inlets, which are the red dashed lines, and the pelvic outlets, which are the blue dashed lines. They're a little bit wider as well. So those are some comparisons of male and female pelvises. And then we'll end here with the lower limb bones. So you have the femur, the patella, the tibia and fibula. Again, no longer known as thigh, kneecap, and lower leg. Just learn the medical names of the bones. The tarsals are your ankle bones. So just like your carpals were your wrist bones, the tarsals are the bones in your ankle. Metatarsals are the bones that make up the sole of the feet. And then the phalanges are the toes as well as fingers. So here are your lower limb bones. You can see that they're arranged very similar to the upper appendage or your arm in the way that your femur is to your humerus, that's your upper bone. And then in the lower leg and the lower arm, you have two bones that kind of sit parallel to each other. And in the lower limb of the leg, you have the tibia and the fibula. The tibia is the bone that will hold up the weight from your femur. And the fibula is kind of a supporting bone on the lateral side of the lower leg. The fibula is flimsy. So fibula, flimsy. Sometimes we get confused knowing the difference between tibia and fibula, but the fibula will be the skinny, flimsy bone. And then you have tarsal bones, metatarsal, and phalange bones in the lower limb. So now we'll go through each one individually, kind of briefly. And then again in lab, you'll spend more time getting to practice all of these bones and what make up kind of the specific pieces of them. So the head of the femur, that's what will fit into the ball and socket joint. The head is surrounded by the neck region. Just like there were tubercles in the humerus, we have bumps on the femur, but we call them trochanters, a greater and a lesser trochanter, but they're better seen on the posterior side. The body of the femur. And then we have the patellar groove where the patella will sit with the condyles, which again are covered with this articular cartilage, which allow a nice smooth, kind of a frictionless connection with the tibia below it. And a little indentation between the two condyles is called the intercondylar fossa. Epicondyles are like little condyles that sit on the sides of those condyles. And then here you can see the triangular shape of the patella below that. So the femur will connect with the tibia on the lateral and medial condyles, and lateral and medial condyles are always labeled for either the lateral or medial side of the leg. And you know that the fibula is on the lateral or outside part of the lower leg. So that's why this is called the lateral condyle next to the head of the fibula. At the bottom of kind of surrounding your tarsal bones or your ankle, you have a lateral and a medial malleolus. And those are the bones that you can feel. If you feel your ankle, you can feel kind of bony projections that stick out, just kind of surrounding the outside of your ankle. And you're feeling the lateral malleolus of your fibula and the medial malleolus of your tibia. And then here are the bones of the foot. The tarsal bones, I don't have a fun mnemonic device to remember the tarsal bones because they're a little bit easier to remember. The calcaneus is your heel bone. And you can see here a superior view and a medial view. The talus is the tarsal bone that connects with your tibia. And you can see that connection happening here. And then you see kind of the navicular bone will be in front of the talus. The cuboid bone will be more lateral. And then you have cuneiform bones. You have 3 cuneiform bones, and they are labeled medial, intermediate, and lateral. You have metatarsal bones, also labeled 1 to 5. Again, number 1 always corresponds to the big toe or the thumb. And phalanx, or sorry, I was going to say something else. The word hallux means big toe. And then you have your digits. Again, you have proximal, middle, and distal phalanges or phalanx for singular, and your toe again can only bend in 2 spots. So you just have a proximal and a distal phalanx of the big toe. So that gets us through the bones of the skeleton. And then we'll just briefly talk about articulations. And articulations is just another word for a joint where 2 or more bones come together. Joints can be classified how they're structured as fibrous, cartilaginous, or synovial, or according to the major connective tissue types that binds the bones together. And if there's a fluid-filled joint capsule present, like your knee or your elbow, joints can also be classified in functional categories according to their degree of motion, because some of our joints, such as our arm and our hip, they're very freely movable, and other joints, like the joints that connect the skull bones together, are not movable at all. So we have degrees of motion and some words that describe these degrees of motions of the joints. So the structural classification first, we have fibrous joints connected by fibrous connective tissue. Different types of fibrous joints are sutures, which are what connect your skull bones together. syndesmoses and gomphoses, and I'll show you pictures. A gomphosis is just a tooth being connected to the jawbone. Cartilaginous joints are united by means of cartilage. You have some subclasses are synchondroses and a symphysis. And then synovial joints are joined by a fluid cavity. And most of the joints in your appendicular skeleton are synovial joints. And then the functional classification of joints, a synarthrosis is completely non-movable. So synarthrosis is non-movable. So an example of these are your skull bones, because they're not movable at all. They've completely fused together and you can't move them. So synarthrosis, non-movable. And amphiarthrosis, think of amphibian, can be like water and land. Amphiarthrosis is in between, slightly movable. And an example of a slightly movable joint are your vertebrae, because your vertebrae can move a little bit. Think your chiropractor can slightly move your vertebrae, but just slightly. And then a diarthrosis is a freely movable joint. And freely movable joints are examples like your knee, your elbow, your wrist articulations. Think of just normal everyday movements of your body. Most are freely movable joints or a diarthrosis. This is a look at fontanelles and sutures. I talked a little bit about this, I think, on Wednesday. A fontanelle is just another word for a soft spot or an area in the skull before the bones have come together and fused. So here's the anterior fontanelle. And then a suture is a fibrous joint, completely synarthrosis. It's non-movable. A suture is where the skull bones will come together and fuse after a year of age. So specifically this anterior fontanelle at the top of the skull, that's easily palpable or palpated. You can feel it until the baby is 1, maybe 13 months old. And you can sometimes see the coursing of the veins. So it kind of freaks you out at first when you see the top of the baby's skull, because you'll see their anterior fontanelle kind of bouncing up and down as blood travels through it, because it's just a piece of skin that's covering their brain. So you never want to drop a baby on its head, especially that anterior fontanelle. Here are the parts of a synovial or fluid-filled cavity joint. You can see where the bones are coming together. The bones are covered with articular cartilage to reduce friction. And then the joint cavity surrounds the bones. It's filled with synovial fluid. You usually have different tendons or ligaments that are kind of keeping these bones stable. The joint capsule itself has a fibrous part, a synovial membrane, bursa, which are extra kind of fluid-filled sacs to help with keeping everything in the synovial joint together. And then these are different types of synovial joints throughout the body. This is a kind of a very all-inclusive list. I can't remember if you guys need to know all of these. Some of these joints are easy to remember. So for example, a hinge joint, and an example of this is the knee or the elbow. Pivot joints are when bones come together and are pivoting past each other. Ball and socket joints are easy to remember, like your hip or your shoulder. So you can kind of have a general idea about the synovial joints. There might be one question from that, but knowing the details of everything on that page is not totally necessary. And then types of movement, we kind of connect the types of movement and describing types of movement associated with joints, because bones coming together form joints, and then they allow you to do different types of movement. These words that describe types of movement are really important only because as you go into your healthcare related fields as an EMT, physician assistant, anything, a nurse, you'll probably read these words in a chart someday, or you'll have to write these words down in a chart someday. This idea of flexion is always bending of a body part or making the angle smaller between two body parts. Extending is straightening. Abduction is movement away from the midline. So right now, if I were to abduct my arm, my left arm, I would be pulling it away from my midline. So that idea of abduction is pulling my arm away from the midline. And then adduction is moving my arm back down to my body or back towards the midline. And you can do abduction and adduction with your fingers. So if I were to abduct my fingers, let's say my middle finger is the midline, this is abduction, kind of moving them all away from the midline. And adduction is moving them back to the midline, which is my middle finger. So abduction and adduction can be done with your legs, your arms. Pronation and supination has to do with rotating your forearm. Yeah, good question. Extension and flexion of the foot. I'll get to that in a good question, Kathy. Yeah. Or I'll talk about it right now. So Kathy has a question about extension and flexion of the foot. Specifically with your feet, it's usually called dorsiflexion or plantar flexion, and it gets kind of confusing there. Dorsiflexion is when you kind of stretch out your toes like that to reach your nose. That's dorsiflexion. And plantar flexion is when you plant your feet down. And I don't know if I talk about those specifically, but yeah, the feet are a little different. Pronation and supination has to do with the rotation of your forearms. So supination is rotating your forearms as if you're holding up cups of soup in your hand. I know this is a silly way to remember it, but supination is holding up cups of soup. And then pronation is the act of rotating down as if you're picking up potato chips. So supination and pronation, rotating the forearms. And then the word rotation is the movement of any structure about the long axis. So here are different types of movement. Really common to see these in physical therapy charts because they will measure the degrees of rotation. But again, for you guys going into any healthcare related fields, or if you're not going to work in healthcare related fields, you might be injured one day and you might just want to know what your PT is writing in her chart. So again, examples of abduction, adduction. A way to remember abduction and adduction is think of a kidnapper abducting someone, taking them away, and then adduction, adding them back. Flexion and extension examples. Other flexion extension examples are if you do kind of bicep curls, those are flexing, and then extending would be straightening out your arm. Pronation and supination, you can remember the holding the soup, supination, pronation, picking something up. And then medial and lateral rotation can also be referred to parts of the limbs. Circumduction is kind of an all-encompassing rotation around an axis. Effects of aging on the skeletal system and joints. Again, we often will end these chapters on the 11 body systems, which with how we are all aging. You have decreased collagen production, you have loss of bone density, which could lead to osteoporosis, osteoarthritis, and also degenerative changes. So the elderly it's just a lot more easily for them to break a bone if they fall. All right, so I'll end the recording and then I'll stay on to answer any questions